Hi, my name is Sara Alhajeri. I'm a medical student from Bahrain. Today I'm going to talk about multiple sclerosis. So I'm going to discuss these different aspects of multiple sclerosis. So at first, I'm going to start with the definition and then the epidemiology and pathophysiology, etc. So at first, what is multiple sclerosis? It is a chronic degenerative disease of the central nervous system, which consists of both the brain and the spinal cord. So what happens is that we have a myelin produced by the oligodendrocyte around our neurons. These myelin will get demyelinated, and sometimes the axon will get degenerated due to the immune-mediated inflammatory process. Therefore, we're going to have delaying signals for the different functions of our brain and spinal cord, like the vision, sensation, movement as well. Like here, you can see the picture of the nerve that's affected with the sclerosis. Coming to the epidemiology, as you can see, females are affected more than males with a ratio of 3:1. The age of onset usually between 20 to 40 years. Different races have different risks. For example, the North European descent have a higher risk than the Asian, African, or Native American descent. It's more common among people who are living more away from the equator. Now I'm going to explain more about the pathophysiology of the disease. So people with MS have they will express a surface molecule which allow the T cell ligand to bind to them. Therefore, the T cell will transfer from the blood to the brain directly, and in the brain, the T cell will get activated once it's bind to the myelin on the nerve. The T cell, once it gets activated, it will increase the expression of the surface molecule on the blood-brain barrier. Therefore, it will allow more of the T cells to bind and more of the T cells to migrate in, which is a type 4 hypersensitivity reaction. After the activation of the T cell, there will be cytokines that are going to be produced that will cause the blood vessels to get dilated and recruit more of the inflammatory cells. Also, the cytokines will cause further damage to the myelin sheath, and it will cause the activation of B cell, where it will produce antibodies that will go and bind to the myelin sheath and trigger its destruction by the macrophage, as the macrophage will go and it will engulf the antibody-coated myelin. After that, the regulatory T cells will come to the battle and it will inhibit the inflammatory response. Early on in the disease, there will be remyelination process that will occur, and some patients will regain their function. However, over time, there will be irreversible damage, and the patient will lose the function of that neuron. The etiology of this disease is usually occur in genetically predisposed individual who has been exposed to environmental factor, being a female and having HLA gene, DRB1 or HLA-DR2, or a gene on chromosome 6p21. It will cause a person to have higher risk to develop multiple sclerosis. We have different environmental risk factors like low vitamin D, smoking, obesity in early life, and pathogens such as Epstein-Barr virus and human herpes virus 6. Coming to the clinical signs and symptoms, different patients will present with different signs and symptoms. The figure on the right, it will show the percentage of the findings that have been reported by the patients or recorded by the doctors. So as you can see, most common symptom or finding is found in the patients is fatigue, which consists of 90%. Optic neuritis is one of the earliest manifestations. Usually it's unilateral and it's painful. The patient will come complaining of impaired vision, color blindness, like sometimes they can say there's a blurry vision, or we can see a black dot in our field of vision. Some of them also have relative afferent pupillary defect, which is explained as Marcus Gunn pupil. We are going to have sometimes intranuclear ophthalmoplegia due to a lesion inside the medial or continual fasciculus, where we'll have demyelination in that area. Most frequently, both eye will be affected, and it will cause ipsilateral medial rectus weakness and lateral gaze nystagmus in the contralateral eye. If the demyelination occurred in the spinal cord tract, for example, in the motor tract, we're going to have upper motor neuron lesion like spasticity, hyperreflexia, positive Babinski sign. If it affected the sensory tract, for example, the dorsal spinal column, we'll have loss of the vibration, fine sensation, numbness, paresthesia, sensory ataxia. Lahertman signs also might be noticed, which is a shooting electrical sensation that travels down the spine upon flexion of the neck. Some patients will experience neuropathic pain and absence of the abdominal reflexes. Also, cerebellar signs might be involved. If the cerebellum gets affected, the patient will have poor postural control, imbalance, gait dysfunction. We have a triad, which is called Charcot's neurological triad, where a patient will have scanning speech, nystagmus, and attention tremor. Some patients might experience transverse myelitis, where they will have asymmetric paraplegia, unilateral sensory loss, and bladder dysfunction. Cranial palsies might be present as well, where they will have diplopia, which will affect the nerves that controls the eye muscle movements, facial palsy, or trigeminal neuralgia, and it can be bilateral. So here we can differentiate between the unilateral facial palsy or trigeminal neuralgia from the bilateral. So they can be scanned in order to check if they have MS or not. Autonomic dysfunctions such as the bowel and bladder disorders and impaired sexual function. The changes in mental status such as depression, emotional changes, memory deficit, they will forget the words that they want to say, for example, impaired concentration as well. They will have reversible exacerbation sometimes due to increase in body temperature, which is called an ortho phenomenon. For example, when they do a physical exercise, take a warm bath, or if they have a fever. So here I'm showing tables of different types of multiple sclerosis based on the type of the symptoms over time. So the first one is the relapsing remitting, where the patient will experience flare-up and then complete or partial remission. The duration between one flare-up to other, it can vary between weeks to years. The secondary progressive, it will start with a flare-up, like it's a relapsing remitting, but after that, there will be a constant progress, a constant increase in the disability. The primary progressive, it's like since the disease onset, since the first flare-up, it will continue, and the disability is higher. So the most common one is the relapsing remitting, and the secondary progressive, around 50% of them will of the relapsing remitting will develop secondary progressive. And the least common is the primary progressive. Okay, so some patients will experience pseudo-relapse, which is the recurrence or significant loss or sensing of existing symptoms due to different stressors. We have also something that's called radiological isolated symptoms or clinically isolated symptoms. The radiologic isolated symptoms, the patient will have demyelination, but he's asymptomatic. He has the demyelination lesion in his brain, but he is asymptomatic. The clinically isolated symptoms, the patient will have the symptoms. However, when we go and do the studies, there is no evidence of demyelination. In order to diagnose it, the patient must fit the McDonald criteria for both dissemination in time and dissemination in space. The dissemination in time is the appearance of new central nervous system lesions over time that can be confirmed clinically with imaging or with the CSF analysis. The dissemination in space, which is the presence of lesions in different regions of the central nervous system that can be confirmed clinically or in MRI. Here is the MRI on the right hand above. You can see the periventricular white matter sclerotic plaque with Dowson fingers. Uh, and below it, you can see the evoked potentials, which is a test in order to record the brain electrical response to different types of stimuli, like visual, auditory, or sensory stimuli as well. These will so we have myelin sheath that will aid to increase the conduction of different signals from a neuron to other. So we do this test to see if the person had multiple sclerosis, that means that the myelin has been lost, so they will have slower messages. So above, you can see the normal speed, and below it, you can see that the speed has been reduced. In this CSF analysis, we're going to take a sample and analyze it. We're going to see high oligoclonal bands and myelin basic proteins as well. We can do blood tests like CBC, vitamin B12, thyroid stimulating hormone, ESR, ANA as well. In regarding the complications, the most important one is the loss of vision. Some patients will have muscle stiffness or spasm, severe weakness or paralysis, balance issues, bladder, bowel, or sexual functions issues as well, cognitive issues like forgetfulness or word finding difficulties, mood problems such as anxiety, depression, and mood swings. It's commonly happened because the patient is living with a chronic condition and is having cognitive dysfunction as well due to the demyelination process, the inflammatory process that's going on. Seizure is rare, however. Coming to the management, so for the flare-up, the acute management, first line is the high dose of IV or per oral glucocorticoid, such as the methylprednisolone, or as an alternative, we have the plasmapheresis or ACTH gel. Regarding the long-term management, we can use the disease-modifying therapy, lifestyle modification, for example, quitting smoking, and comorbidities management. For example, if the patient had cardiovascular disease, we should treat it, give them the treatments required. Vitamin D supplements and symptoms management, like for spasticity, neuropathic pain, bowel and bladder dysfunction. There is no cure, but we can manage the symptoms and avoid the flare-ups. Okay, so the disease-modifying, you have different drugs that can be used for different phenotypes. For example, in the clinically isolated symptoms, we can use the interferon beta and glutamate acetate, as well as the trifluomapide. In the relapsing remitting, we can use all of these in addition to this siponamide and the monoclonal antibodies, natalizumab, ocrelizumab, and emtezumab. In the secondary progressive, we can use all of them. Primary progressive, it's preferred to use the ocrelizumab. So here I listed the medications and the mechanism of action of each. Coming to the interferon beta, it will be targeted toward the T cell activity. Therefore, it's going to decrease the cytokines production. The glutamate acetate, it's a decoy for the T cell and instead of neuronal myelin, and it will decrease the pro-inflammatory T helper 1, and it will increase the anti-inflammatory T helper 2. The trifluomamide, it will inhibit the pyrimidine synthesis, which is an anti-proliferative and anti-inflammatory effect. Coming to the monoclonal antibodies, the alemtuzumab, the monoclonal antibodies, they have different targets. So the first one, the alemtuzumab, is going to be targeted against the superficial antigen CD52 on the lymphocyte and monocyte, and it's going to deplete both B and T cells. The natalizumab, it's going to be targeted against the alpha-4 integrin, and it will inhibit the invasion of the lymphocyte to the CNS. The ocrelizumab and ofatumumab, it's going to target the CD20, and it will deplete the B cells. Okay, coming to the symptoms management, for the urinary frequency, we can do the pelvic floor muscle training, bladder training. For the urinary retention, we can do the intermittent catheterization, or sometimes we can use the parasympathetic drugs. For the bowel dysfunction, we should do dietary modification and increase the fluid intake, give laxative, stool softener like diclofenac as needed. Regarding the spasticity, we can increase the stretching exercises and avoid the triggers, such as position, pain, constipation. We can use medication, which is the baclofen, which is a centrally acting GABA agonist. For the tremors, we can do deep brain stimulation to alleviate it, or we can use medications such as the propranolol or gabapentin. And for the central neuropathic pain, we can use the amitriptyline, which is a tricyclic antidepressant, carbamazepine, gabapentin, which is an anticonvulsant, or for the trigeminal neuralgia, we can use the transcutaneous electrical nerve stimulation. For the walking difficulties, we can use mobility aids or use a drug like delafamaparidine. Okay, coming to the fatigue. Fatigue is the most common symptoms that the patient with MS will come complaining of. So we can give either amantadine or modafinil. Psychotherapy, it's important to reduce the potential psychological issues such as depression. All of the physical therapy, occupational therapy, psychotherapy are important in order to improve multiple symptoms that a patient with multiple sclerosis suffers from, such as the spasticity, fatigue, walking difficulties, and central neuropathic pain. So MS in pregnancy, it has effects on both. Like the pregnancy has an effect on the multiple sclerosis disease. It will decrease the risk of exacerbation during the pregnancy. However, postpartumly, there is a high risk for the exacerbation. However, the clinical course of the multiple sclerosis will remain unchanged. The multiple sclerosis will lead to increase the rate of the elective cesarean sections and decreased birth weights. I have included my references here, and I have an osmosis video that explains the pathophysiology of the disease. Thank you. Do you have any questions?